All right, this evening our guest is Patrick Coughlin. He's Vice President of Partner Engagement for Medical Benevolence Foundation. MBF for over 50 years has been the independent nonprofit organization working in partnership with individuals and churches throughout the U.S. to equip Presbyterian partners in developing countries to proclaim the gospel through medical ministry. WCPC has supported MBF for nearly 30 years. In recent years, we've also helped support the MBF if they begin developing funds to develop and deploy their 21st century medical mission model. In April, Patrick and Dr. Valen, the surgical residency program director at the Nkoma Hospital in Malawi, visited WCPC to give us an update. And when we found out that Patrick was going to be in town this week, we asked him to speak with us again. So Patrick, welcome to WCPC.
Thank you so much, Gary. I really appreciate that. Y'all are going to get tired of seeing my face, but it's nice to see some different folks than were able to make the meeting in April. I just, first of all, want to thank you for your faithfulness, because we've got folks all across the country, but not a whole lot of them have been partners of ours like you for 30 years. We've been around this summer. It will be 60 years. And so you've been with us halfway of that journey. Really is amazing when you think about the compounding effect of what your ministry has done over that period of time. The thousands of lives that have been impacted, the mothers, the babies that have been saved, critical medical services that have been provided, but most importantly, the witness to Jesus Christ that has presented. In some of these areas, our partner hospitals are the only ones that are sharing the good news of the gospel, and people may not be exposed otherwise. At the same time, when individuals come to an MBF partner hospital, that expectation of distinctively Christian is an expectation. And so it's a blessing to be able to represent you on a daily basis and share stories and share progress. So tonight, I'd like to talk a little bit about a couple of different things. I know some of you were at the meeting in April, but I would like to just touch on some of that information and share some of that information again, not all of it, but some of it, because I think it puts into perspective for all of us what it is your ministry is trying to do and how it is we're trying to do that. But I do have a lot of additional information I'd like to share with you tonight as well. So as Gary mentioned, you all were really at the forefront pre-COVID in helping us launch what we call the 21st century medical mission model. What we mean by that is there have been major changes in medical mission ministry over the past several decades, but it's really accelerated in the past 10 years or so. There aren't long-term missionaries anymore. Let me correct myself. There are long-term missionaries today, but a long-term missionary is maybe 5 years. When my aunt became a Catholic nun and became a long-term missionary, she gave her entire life to serving the poor in Africa. That's what the missionary model used to be. Today, it's much different. So how do we address that with partners? In addition, there's a shift in disease burden. Communicable diseases are starting to go away. but chronic diseases are becoming more prevalent in our partners, developing countries. And in addition to that, there's a tremendous amount of preventable and treatable illness that has gone untreated. So there are three big drivers here in these developing countries that are really making us and forcing us to rethink and reshape how medical missions ministry can be handled. At the same time, now that the missionary model has changed, now that the Western church in some cases is struggling to hold on, and what I mean by that is there are just fewer people that are affiliated with any denomination, let alone the Presbyterian. There are fewer people going to church today than there were 10 years ago, and certainly fewer people than there were in the 70s. And so we understand now that the local church, meaning the in-country church, in-country meaning Malawi, Kenya, Zimbabwe, Mozambique, wherever it happens to be, the local church needs to be the driver and the owner, because that's really how sustainability is. If they take that ownership, if we build in practices, not only from a clinical side, but an administrative side that helps sustain those ministries long after we're gone. We need to make sure that the clinical care is meeting international quality standards. We like to say good enough is no longer good enough. Even in rural developing countries, the expectation now is the quality of care is going to be the same. The environment's going to look different. The quality of care is going to be the same as we would expect here in Houston, or we would get in Washington, D.C., or where I live in Charlotte. We are focusing on developing systems that can be replicated, that can be scaled, that can be adapted to different regions, different cultures, different environments, and different countries. But most importantly, faith is integrated into everything that we do. We work uniquely with church-owned hospitals, clinics, nursing schools, partners. We don't work with government hospitals. We don't work with privately owned hospitals, because faith is a critical component of healing the body. There are 30 plus references in the book of Acts of the apostles healing and sharing the good news. Sharing the good news and healing, those two things going hand in hand. We take that very, very seriously. So that's kind of the environment that we find ourselves. What I'd like to share with you is what's happening today in Malawi. Over the past 5 years or so, we've really seen from our investment in that country, we've really seen an acceleration of a countrywide Christian medical network that has developed in Malawi. And what we've seen has been remarkable because new partnerships have developed. And if you think about it this way, this hospital, when it was founded, let's say 100 years ago, has been operating as a standalone island. And this clinic has been operating as a standalone island. What NBF is doing is reaching out to these different clinics, hospitals, nursing schools, different denominations, and saying, we can all do much more if we work together. And that idea of building networks has really become the bedrock of our future plans. Using this Malawi model, as we like to call it, hospitals networked with clinics, networked with nursing schools, all working together, has really been transformative. Think about this. This is reality. This isn't a made-up story. These clinics around these hospitals often don't even know that this hospital is in close proximity. So a patient comes in and it's beyond their ability, they're presenting an illness or an injury that's beyond their ability to treat. they haven't been able to refer them to anyone because they've been operating as islands. What MBF has been trying to do is get these hospitals and clinics to work collaboratively, so that they can refer patients from clinics to hospitals, so that hospitals can help these clinics manage themselves, order supplies, order equipment that they need. So it really becomes a comprehensive network. So what our vision is to take this network model and to expand it to 10 new countries over the next 10 years, and God willing, 20 new countries over the next 20 years. We have more hospitals and more clinics that will continue to be added and built out and build out this backbone that we have and really put some more flesh on the network in Malawi. But at least it's showing us proof of concept that not only can we pull these organizations together, but something that I want to point out here right in the middle of the slide. These are not all Presbyterian facilities. They're Presbyterian and Catholic and Seventh-day Adventist and Methodist, but they're all working together for the common good. And that is to treat the patients in front of them and to share the good news of the gospel. Now, I mentioned that we hope to expand this network idea to 10 and then 20 new countries. We know that every country is going to be unique, and we know that every country is going to require a tailored approach, and we know that the timeline is going to look very different in every single country, but at least we have the blueprint in place that we can use. So let's drill down for a moment and let me share with you a little bit about what's happening specifically in Malawi. We shared with you some news about Nkoma Hospital, which is a 100-plus-year-old mission hospital that started as a clinic and grew and grew and grew. And now you see the complex of buildings all over its footprint now. And this 100-year-old mission hospital is now transitioning to being a teaching hospital in one of the poorest countries in the world, Malawi. And that just, to me, is an overwhelming sign of God's grace and his goodness and his faithfulness. I would love to be able to go back to those initial missionaries that founded this hospital and say, did you know that this hospital someday will be a teaching hospital? I'm sure that they never would have, in their wildest imagination, dreamed that something like that. And what's happening is, first and foremost, the advent of a surgical residency program. Dr. Jens Valen, who's on the left-hand side here of the screen, is a surgeon from Germany. He's a missionary who is the program director of the surgical residency program at Nkoma Hospital. He visited the States back in April for MBF's board meeting, and we were able to bring him by to visit some folks when we were here in Houston. So Dr. Valen is the program director, but Dr. Yamakani Limbe, who's pictured on the right, is a Malawian surgeon. Dr. Limbe did his residency in South Africa, but he has such a passion for helping his people. Instead of staying in South Africa where he could earn more money, he made the decision to come back to Malawi. Dr. Limbe is the assistant program director for the surgical residency. In 2 more years, Dr. Valen's contract expires, and he will either go back to Germany or go to another country, which means in 2 to 3 years, Dr. Limbe, a Malawian surgeon, will then be program director of the surgical residency program. So I share that with you to say, if you think about what we were talking about on the front end, building in sustainability from the get-go, this is an example of that. This is not about having Western missionaries always be there to be teaching. This is about building the capacity of Dr. Limbe, of Dr. Vitu, Dr. Caleb, Dr. Madalitzo, Dr. Wangani. These are our current residents that are in the program. These men will not only be surgeons in treating people, but these are the leaders of the surgical residency program in the very near. So as we launch this surgical residency program, you can imagine we also realize that a program is nothing without a facility. And so in the plans is a new surgical center at Encoma Hospital. We're working to renovate part of the hospital, part of the existing hospital, but we'll also be doing some addition to that as well. Up until 2019, there was never a surgeon that was resident at Encoma Hospital. They didn't have a surgeon. They had a bunch of doctors, but there was no surgeon. Now, there are 5 teaching faculty, all surgeons. There are 4 residents, all surgeons. There are now 9 surgeons at Encoma Hospital. Well, guess what? When you have 9 surgeons, you need places where they can operate, right? So we're expanding the operating theaters. We're building new operating theaters. There were only 2. We're renovating those 2 existing ones and building 4 more. We're adding a 9-bed ICU because guess what? When you come out of surgery, oftentimes you need to be in intensive care for a certain period. So we're building an intensive care unit. And along with that, the level of training for the nurses and the staff needs to be stepped up as well. An ICU nurse requires a much different level of training to be able to care for those patients than somebody in the general medical. In addition to the ICUs and the theaters that we'll be building, on the second story of this facility is going to be the training center. So not only will there be education and training going on for the surgical residency program, but since this is going to be a teaching hospital, this education center can be used for other specialties as well. There's a family medicine residency that has started now. We're talking about developing internal medicine residency programs that have all the ologists, pulmonologists and cardiologists and all the ologists associated with them. So this training center that we're investing in is not just for the surgical unit, it's going to be for the teaching center. So you may be asking yourself, why is MBF doing this? We understand the need to provide medical care in developing countries, but why are you investing in trying to build the capacity of the indigenous population? Simply put, thousands of underserved and marginalized people are dying daily. And if you look at this chart that shows very poor nations on this side and very rich nations on this side, very sick nations down here and very healthy nations up here, if you look at the poor and the sick countries, they're almost all in Africa. And many of the, much of this suffering, many of these deaths, many of these conditions are from preventable causes. There's been a study by the WHO that indicated 30% of the population in Malawi is living with a condition that can be helped by surgery. 30%. So you say, well, why aren't they getting surgical services for it? Because there aren't enough surgeons for it. So understanding, that these countries are where the poorest and the sickest people are. So if we can begin investing in these countries and building the capacity of the church-owned hospitals and clinics, not only is the hope that we can change, we know that we can change the outcome. So your question may be, will investing in a country like Malawi really make a long-term difference? It's great that we met Dr. Limbe and saw his picture and that he's stepping up. And it's great that we see these surgeons, but really we can all get excited about what's happening today and what's right in front of us. What is the long-term implication of it? Well, without a doubt, programs and investments like this are going to change these countries. And don't take my word from it, for it. These are statistics that come from the McKinsey Global Institute, and they did studies of investing in healthcare in the different continents. And so we pulled out of this study what they found about Africa. So by investing in healthcare, by prioritizing healthcare, there can be a dramatic impact in the sub-Saharan African country. There's a reduction of poor health. There are additional days that a person in the workforce can work. There's a higher level of productivity that the workforce can achieve. And here's something that, Here's something that I want to point out to you. For every dollar that is invested in healthcare in African countries, there is an economic benefit of $2.70. That translates into increase in GDP, that increase on a personal level, that increases the income level of the workers and the workforce. So it's not just something that MBF says, hey, this is a good idea. We need to go and heal the sick and preach the gospel in Africa. We're actually looking at this as an investment that long-term is going to transform the country. So by creating these networks of medical care, Christian medical networks, there's going to be a dramatic change, not only in the quality of care, but also in how the hospitals and clinics and churches all interact together. So there's a need for stronger leadership and stronger administration. Our model helps develop those systems of better governance. There's a need for higher level of quality care, international quality standards. Our model helps our partners develop ways to provide evidence-based international quality standards of medicine. There's a need for better governance, better oversight, better financial practices. Our model addresses the system holistically. So it's not just about sending a missionary doctor for 5 years to provide medical care. It's about going, teaching, empowering, equipping, and helping our partners do what they've never been able to do before. So before I open it up for questions, I'd love to hear what your thoughts are and answer any questions that you have. I want to close where we started, and that is with a huge thank you. Next year, 2024, marks the 30th anniversary of our ministry together. And we've already been having some conversations about how do we mark this anniversary of ministry together. how do we honor those who went before us, both at Woodlands and at MBF, and establish that relationship back in 1994? How do we honor what they do and really prepare for the future? And I'll tell you one thing: we're going to come and have an anniversary party, and I'm going to bring a big old cake that we can all share, be a part of it. But we're also talking about other ways, and maybe taking a group over to see what's happening in Malawi. Or maybe by that time we'll be expanding to a new country, and we can go and see how that expansion is going. The bottom line is, you have been a faithful partner in healing the sick and sharing the gospel with those who, in some cases, many cases, have nowhere else to turn. The most vulnerable, the most marginalized, women and children who in some of these cultures are treated as disposable because they can be replaced. And so they have nowhere else to turn except one of the MBF partner hospitals. You've been there for 30 years, taking care of these individuals, taking care of these mamas, these babies, helping families survive and make it through a situation that could have devastated the family. You know how a medical emergency here in the United States can really cause a havoc in a family, even more so in the developing world. And I think about the thousands upon thousands of lives that have been impacted because of your faithfulness over the past 30 years. And I'm just really very, very humbled and very, very grateful for all that you have done, for the commitment that you continue to make on an annual basis. So with that, I'm going to stop my screen share, and I would be happy to answer any questions that you might have. I'd love to hear any feedback that you might have about what we're trying to do and how we're trying to do it.
Patrick, a quick question.
Yes, sir.
I'm wondering, based on everything you've said, what you find when you go into a new country that needs to happen so that the financial aspects of the hospital that you're trying to enhance or establish is sustainable financially in the long run. You know, in the US, we'd say that amounts to healthcare plans and, patient revenue and all that stuff. Is there a financial side of this that needs to get bolstered too?
Absolutely. And that's a great question. And this is God's providence. So let me pull up for you. I happen to have this open. I don't believe in coincidences. So Todd, we have to that point, we have pulled together this website, which is in its infancy, and it is about to go live a little bit later this week. But what this website does is it has created a dashboard of countries that we are looking to expand to. So when we look at the sub-Saharan countries, and let's go to Zambia as an example here. Not only are we looking at the medical issues in Zambia, meaning what are cancer rates, what are HIV rates, are they growing, are they shrinking, but we are also looking at the demographics. So what are the population details? What are the economic details? What are the health system details, meaning where are the hospitals? Are they owned by the church? Are they owned by the government? How many doctors do they have? How many nurses do they have? So to in a very long-winded way of answering that question, as we look at our short list of countries, that is a significant consideration. In general, there's a growing middle class in Africa. In general, every country is better off today than they were 5-10 years ago from an economic standpoint. But if you look at Malawi as an example, Malawi is still in the bottom 5 countries in the world in terms of being the poorest country. You look 10 years ago, Malawi was in the bottom 5, and you go, well, they haven't grown at all. Well, yes, they have, because that's in comparison to the rest of the world, but there's still a rising middle class. There's still more disposable income today than there was. So that dashboard is helping us quantify what those economic measures are, because we need to make sure that, especially in the initial countries where we're going to continue to invest, that there is at least a reasonable expectation that a portion of the population is going to be able to pay for part, and in some cases, all of this specialized medical care. Does that make sense?
Absolutely. Yeah, thank you.
Sure, sure. Doug, you raised your hand a minute ago, I think. Did you have a
Yeah.
question?
I'm going to assume, but tell me if my assumption is incorrect, that the national and the local governments in Malawi are good partners, and they help you guys grow what you're doing in country there. I'm curious as to what challenges you might see or that you already expect in other countries as you go along.
Yeah, that's that great question, and that's a major consideration. Let me contrast 2 countries, Kenya and Malawi. So Kenya has a national medical insurance program. Doesn't pay a lot, doesn't cover the entire cost, but it does do some reimbursement. So in that case, the government of Kenya can reimburse our partners for some of the care that they provide, especially to the indigent. So that's a very active role that the government plays, and that's great. That's what we love. In Malawi, the government loves us because we're solving a problem for them, and that is we're treating the poor. If you go to a government hospital in Malawi, you don't have the money to pay for care, you don't get treated, even though it's a government hospital. So the government loves our partners because they are providing a service and answering a problem that the Malawian government doesn't want to deal with, and that is healthcare for the poor. So we understand that in these different countries, as we expand, every government is going to be somewhere on that spectrum, and maybe there are even farther extremes of either one of those. But we do understand that in some cases, the governments may take a very proactive approach. In some cases, may be at best passive. If a government is going to be hostile to a Christian hospital network, we're going to have to really think long and hard about going there. But I will tell you that we have partners in Pakistan, which is not a Christian country. They are Christian hospitals, and they are not demonized. They are not persecuted. They are not facing any problems from the government or from the Muslim population, again, because they treat anybody regardless of their ability to pay and regardless of their religious beliefs. So even in a Muslim country like Pakistan, we're seeing great success in being able to establish distinctively Christian medical care. Interestingly enough, it is very difficult to keep that hospital supplied with Bibles, with tracts. There's just this hunger, this desperate thirst and hunger for knowledge of Jesus Christ. People come there, they're treated, they're prayed for, they're prayed with. They've never seen anything like that. And they're healed in part because of the doctors and the nurses but also because God is intervening there in a way that we've never seen. And so it's opening up doors to share the good news and share the gospel even in the Muslim.
So is it fair then to say that, like in that extreme case that I just gave, or like you talked about where they might be hostile, you're not, at least right now, you're not seeing that being a problem, at least not yet.
Not yet.
Not on the far end of the spectrum anyway.
Correct.
That's okay.
That's
That's good.
and Doug, honestly, the countries on our short list, we've got about 15 countries on our short list, are all either Christian countries or very warm to Christian and accommodating to Christians. So we want to build around our strengths, right? At least initially. Now, if funding were not a question and we could go to 20 countries tomorrow, if we had the funding to do that, well, we'd find a way to do that. But we have to walk before we can crawl, or before we can run. And so we're going to start where we've had some historical relationships, start in countries where there's distinctively Christian leadership and a strong church, and get some early wins and build that momentum so that this network idea can take hold in these countries and then spread to others as well. Other questions or comments?
Yes, the website that you showed, that you
Yes.
could drill, is that going to be available on your regular website, or how would we be able to get to it once it comes up?
Yes, it will. Stan, thank you for that question. What I'll do is I'll make sure that we launched the prototype a couple of weeks back. We're going to have it go live, but we're still going to be doing some testing around it before we kind of announce it. So it's going to be live. It's just you're not going to know how to find it. So we want to do some testing and we've got an advisory council that has helped us with technology folks, with folks from Department of Health and Human Services, physicians, financiers, philanthropists. We've had this advisory committee that's helped us create this. And so we want to launch it to them first and get them to kind of use it and play around and make sure that it operates the way that we expect it to. I would say probably within a month, maybe 6 weeks or so, we'll be able to share that. And so I'll make sure that Gary and Sonia get that link. And yes, we will have it on our website. It'll just be on a subpage and we'll be sure to share.
That'll work out really well, since once Sonia or I get it, we'll distribute it to our mission outreach team. But the way our website and partners are listed, when you click on a partner on our website, there's a hyperlink that will take the viewer to your website as well. And then from there, they can go directly into it.
Great.
So it'll be real easy for us to set up.
That's great. And right now the dashboard is built with data around our 15 shortlist countries. But once we get that up and working the way that we want to, all we have to do is populate the data for all the other countries in sub-Saharan Africa and Africa as a continent. And then we can do every country in the world if we wanted to, because we think that this is going to be a valuable tool, not only to MBF and our partners and hopefully to you, but also to other mission organizations. Will Samaritan's Purse be able to use this and be able to make informed decisions? We certainly hope so. Will Waters for the World be able to use this and make informed decisions? We certainly hope so. We don't want to hide this light under a bushel basket. We want to put it out there and allow anybody to use it that's in that space in the world.
Yeah, it seemed to be a valuable tool that,
Absolutely. That's what we're hoping. That's what we're so. By the way, I want to give credit. We contracted with the Institute for Health Metrics and Evaluation, which is a part of the University of Washington. And the Institute has received significant funding from the Gates Foundation for the years to help pull together this data from all these different sources. And they've just been amazing in helping us find all this data and put it together to create these country by country profiles. When we went to them with the idea, they almost said, "Oh my gosh, how come nobody's ever done this before? What a neat idea." And it's going to be helpful for everybody. And since they've already gathered the data, it was just a matter of pulling it together and putting it into a visually appealing type system. The hard work was already done. It was just creating, a website and a dashboard that was easily navigable and informative. So they did the heavy lifting, and thanks to the huge thanks to the Gates Foundation, because they funded all of that work over the past 8 to 10 years.
Any other questions or comments? Well, Patrick, once again, thank you so much for spending some time with us. Look forward to seeing you the next time.
Oh, my pleasure, Gary. I really appreciate it. Since I've moved into your house here, I might see you for breakfast, and we can talk about it a little bit more.
Yeah, we can. Well, you certainly need to take the dog for a walk, if you would.
Yeah, I'll be happy to do that. I will be happy to do that. But we hold our fall board meeting in Houston every single year, which means we are typically bringing in not only our board members, but sometimes experts from the outside, and always individuals like Dr. Valen, who you met, Dr. Douglas Lungu, who's our medical director, who is Malawi and lives in Malawi. He always comes in for our board meeting. So as opportunities arise, we'll keep you informed. And if there's a chance that we can bring somebody by to meet you all, or even if it's over Zoom, that would be great too. We want to keep you informed of what your ministry is doing. Again, thank you so much.
Thank you.